Started, no?
Yeah.
Hi, friends. As all of you are aware, there is a huge controversy regarding the efficacy of hydroxychloroquine and chloroquine, both used as anti-malarial for ages in the treatment of coronavirus disease. With Trump recommending it and FDA contradicting it, and again ICMR recommending it prophylaxis in high-risk exposure. Today's presentation, I would like to emphasize on what is the real evidence of hydroxychloroquine use in the management of corona disease, both in prophylaxis and treatment. The first disclosure, the most important thing is this is strictly for use of medical professionals, because most of the slides are looking at the evidences, and please don't share this with non-medical people. The first, what is the rationale of using chloroquine? And then I will go back to evidence from basic studies, then look at what is the evidence from clinical studies and trials in treatment and prophylaxis. So when we look at the coronavirus disease, it has two phases. In the first phase, as you can see here, the virus enters the body, multiplies, causing viremia, affect the lungs. Later on, the host inflammation takes place, and host inflammation sometimes cause hyperinflammatory state, leading on to cytokine storm. And the cytokine storm sometimes, most of the time, is counterproductive, and this can lead on to death of the patient too. Chloroquine and hydroxychloroquine has been used for ages. The first apparent use was the quinine started in the age 1630, which was a miracle tree, which was the name was given, cinchona was given in 1740, and more than 250 to 300 years. This has been in use. In 1930, for chloroquine synthesized, and FDA approved chloroquine in 1949. From 1970s and 80s, chloroquine has been used in the treatment of rheumatoid arthritis, lupus as an immunomodulator. The point I'm trying to make is, this drug is in use for very, very long time. It's widely available, and we have a lot of safety data of this drug. How does chloroquine really act? This anti-malaria, as you know, once an antigen comes to a cell surface, this antigen is taken up by the cell. It is processed in endosome, and broken down into particles, and then it is loaded onto MHC, or major histocompatibility complex, and then this MHC and antigen complex is later delivered to the T cells, and which will lead on to immune stimulation, cytokine production, and elimination of antigen from the cell, from the body. This is how the normal immune system works. The hydroxychloroquine, how does it work? Is basically it increases the pH of endosome and lysosome. And by increasing the pH of the endosome and lysosome, it interferes with the antigen processing and antigen presentation. As you can see here, when the pH is increased, the endolysosome doesn't function normally, and the MHC class 2 mediated antigen presentation is inhibited. Similarly, by inhibiting TLR pathway, TLR is nothing but a toll-like receptor pathway, it inhibits cytokines production. The first and foremost action of hydroxychloroquine is to suppress the hyperinflammatory response in the second stage of COVID. So it decreases the cytokine storm. But there's more to it. It has been shown in basic studies that hydroxychloroquine interferes with the ACE2 receptor inhibition. What is ACE2 receptor? ACE2 receptor is nothing but a receptor for coronavirus to enter the cell. Hydroxychloroquine interferes with the glycosylation of this ACE2 receptor so that the coronavirus cannot come and bind to the receptor. That is the reason people believe that hydroxychloroquine can be used as for prophylaxis therapy also. More than that, by increasing the pH in the endolysosome, it inhibits the viral replication. How does that happen? After entering the cell, coronavirus uses this endolysosome to replicate and multiply. By increasing the pH, hydroxychloroquine inhibits this viral multiplication and replication. So how does it inhibit the virus? By two ways. One, it inhibits the receptor, or it downregulates the receptor on cell surface. And secondly, it inhibits the multiplication in the endolysosome. So it is an antiviral too. That's why people started believing that hydroxychloroquine has a mechanical plausibility to be used in novel coronavirus disease. So it can act in both ways. On one side, it inhibits it has an antiviral effect by inhibiting the viral entry and replication. On the other side, it can inhibit the cytokine storm. So mechanistically or theoretically, it is a wonderful drug having both these effects, which can tackle both the phases of coronavirus disease. So people started, this is a very old paper, which was published in Virology Journal in 2005. But this is basically, they have studied with SARS coronavirus. They took a cell line called vero cell line, which was infected with virus and treated with different doses of chloroquine. And they looked at whether usually this virus infects the vero cell and kills it. You can see here, if you are not treating anything, just you are putting the vero cell along with the virus, all the cells are infected. Then if you increase, then different concentrations of chloroquine is added. As you can see here, from this below panel, most of the cells, the cell density is much less, infection is much less. If you look at the type of percentage of inhibition, this is percentage of inhibition, and on the what is plotted on the x-axis is basically the concentration of chloroquine. You can see here from 10 onwards, the inhibition is significant at the around 33 to 100 microgram per ml. It is micromoles. There is more than 95% inhibition of the viral entry to the cell. So it's effective. So can be used for prophylaxis. The first one, what they have done is they have added virus first, then they have added chloroquine. The second one, what they have done is they treated the cells with chloroquine for 2 hours. Like what we do in prophylaxis, we take the drug before the virus enters, then treated with virus. What could they see? If you can see here, in the untreated vero cell, they are widely infected. The moment you treat with chloroquine, the amount of, you can see the red cells are not seen in the below panels, indicating there is a chloroquine definitely inhibits the viral entry into the vero cell. And you can see this, in the 10 micromoles, the inhibition of the cell virus entry is up to almost 100%, indicating there is a role in prophylaxis too. So what is the effective concentration? Second thing is, once you think that chloroquine and hydroxychloroquine and inhibit the virus entry and inhibit the virus multiplication, then you look at whether what is the concentration is required so that the chloroquine and hydroxychloroquine can be used, whether it's then the toxic levels of human body or not. So for that, they have infected the vero cell infected with virus and cultured with chloroquine and hydroxychloroquine at different doses. You can see here the EC50 of hydroxychloroquine is 0.72 micromoles once it is treated for longer time. For example, this is the 48 hours culture and 24 hours culture. If you treat it for longer time, it can be achieved at a 0.72 micromoles, which is normal dose which is achieved. Samely with chloroquine has a higher EC50. So this indicates 2 points. Hydroxychloroquine is more potent because the EC50 is low in hydroxychloroquine when compared to chloroquine. And second thing what it indicates is that if you treat it for longer time, you can, with a lower dose, you can achieve the inhibition. EC50 is nothing but 50% of the effective dose. What about prophylaxis? How much is the EC50 for that? They again repeated the same experiment. You can see here, EC50 is 5.85 here. And in hydroxychloroquine is not very good for prophylaxis because, as you can see, EC50 is very high. So hydroxychloroquine is better than chloroquine for prophylaxis. Maybe for treatment also, that is better. Another very important feature came from this I saw this in very old study where they gave 40 milligram per kilogram per day, very, very high dose of chloroquine to these patients. And they looked at which are the tissues which are this is concentrated. As you can see, eye has the maximum. That's why the chloroquine patients, once they take for a long time, they develop eye toxicity. Another organ, lung, also has a very, very high concentration of chloroquine once given for a long time. So that's a good feature for coronavirus, because coronavirus, as all of us know, affects the lung primarily. So once you have concentration in lung, what is the desired concentration? For, as we know, what we need is EC50. So as I told you in the earlier slides, EC50 is around 0.7 or 0.5 for hydroxychloroquine. So they looked at whether the concentration in lung is adequate. So for that, they took a ratio of concentration in the lung divided by EC50 by pharmacokinetic modeling. And what we need to achieve is EC50. So EC50, this has to be around 100%, or the ratio has to be 1. So as you can see here, if you give a higher dose of 1200, EC50 is reached on the day 5. If you give it slightly lower dose of 800 milligram, and then you maintain it with day 2 to day 10 with a 400 milligram, and day 5 you reach EC50 of 85%, and the levels keep on accumulating. Same with this also. Even if you get 5 days, it's not adequate. Usually what you require is you give 800 milligram on day 1, and then give 400 milligram from day 2 to day 10. So day 5 or day 6, you achieve the levels. The first regimen is slightly faster, but 1200 milligram can cause a lot of gastric discomfort. So looking at this data, it appears that to achieve a very good EC50 concentration in lung, this regimen appears to be good. On day 1, you can give 400 milligram BD, and from day 2 to day 10, you can give 200 milligram BD or 400 milligram OD. So high loading and low maintenance is done because of 2 reasons. Because once you give high loading dose, there is high accumulation in the body because of the long elimination half-life of hydroxychloroquine. This study, which was again published a couple of weeks back, where they looked at again they took the Vero cell line infected with virus. This is one of the cell lines which has been used extensively to study this virus. It was cultured with multiple agents like ribavirin, chloroquine, remdesivir, and favipiravir. All these are antivirals, and they studied chloroquine also. As you can see, ribavirin and favipiravir was not effective. I am not showing the data here, but chloroquine and remdesivir were very effective. How do you know that? What they have shown is percentage inhibition of the cell entry, percentage of inhibition by these 2 drugs. As you can see here, this is the control. When compared to control, this is the, if you treat, so this is not control, this is the, once you treat the chloroquine full time, it gives, and remdesivir full time, you get a reasonably good amount of inhibition, but remdesivir is only effective in post-entry phase. It is not very effective in the entry phase, so you can really use it as prophylaxis. Remdesivir only acts once the cell is infected with virus. That because of its mechanism of action, but hydroxychloroquine achieves around 70 to 80% of the effect. Once it is giving full time, it achieves a 60% inhibition for prophylaxis and 40% inhibition for post-entry phase. Because of the reasons I told you in the second slide, hydroxychloroquine inhibits both the entry of the virus into the cell, its multiplication also. So it is effective in both the stages, in the entry and post-entry, while remdesivir is effective only in the post-entry phase. So it appears very promising. Remdesivir is effective after entry, chloroquine is effective before and after entry. So it can be used for prophylaxis too. So what I have summarized till now is evidence from basic studies, very good results in in vitro studies, and that's why people thought they will go ahead with clinical trials. And people started trying this. So this is the French study all of us must have seen. This is what President Trump told us about. It was widely circulated in newspapers, Twitters, and what the study shows. This is the control group. This is the blue line, the chloroquine group, and this is the chloroquine and azithromycin group. So what happened here? In this, what is shown in this chart is that the patients who are having control group and they did not have viral inhibition, or they were having persistent virus at the end of day 6. But those who are on chloroquine, as you can see, around 60% or 70% of them had PCR negativity, while you give azithromycin and chloroquine, most of them had viral PCR negativity at the end of 5 or 6 days. Very significant. From the chart itself, you know, this is a very significant result, and that's why so much hype was there. Later, this study, couple of weeks or 7-10 days earlier, the study was published, and more data we have. Let us look at the data more closely. So what they do, this is a French study, French group, which published. They took patients who are aged more than 12 years and who had PCR documented coronavirus carriage in the nasal pharyngeal sample. And they excluded those who have allergy to chloroquine, G6PD deficiency, or those who had QT prolongation. How they did this? It's a non-randomized trial, as they have told. But they have two centers. One center called Marseille Center. Everybody got hydroxychloroquine, and in some other centers were taken. Patients in other centers were taken as controls. So it was not a strictly randomized control trial. And they were included 42 patients initially, and 26 patients were given 200 milligrams of hydroxychloroquine 3 times a day, and 60 patients in the other centers were acted as controls. Of these 26 patients, 3 patients were transferred to the intensive care unit, 1 patient died, and another patient left hospital because of he didn't want to continue the treatment, and 1 patient stopped treatment due to nausea. While in the control arm, they were given standard of care, all patients completed the follow-up, and none of them has transfers to ICU, nobody died, and none of them defaulted. The problem is, in the final analysis, out of these 26 patients, only 20 were analyzed, and these 6 patients were excluded. And then they compared 20 patients with 16 patients in the control. 20 patients in the chloroquine arm and 16 patients in the control arm. In these 6 patients, HCQ was stopped. No reason is mentioned. Those patients who became sick, chloroquine is stopped. And 4 of them are really sick and 1 died. 3 were transferred to ICU, and they were excluded from analysis. This gives a huge bias in the analysis, because if you look at this data, 26 patients on chloroquine, 4 of them had a really bad outcome. 3 were transferred to ICU, 1 died, and 16 patients in the standard of care, they did well. And the final analysis, the initial 6 patients of this were excluded. So that is a very, very important point which we have to keep in mind once we are analyzing the last data. If you look at the baseline characteristics, those patients in the control arm were younger. As we know, patients who are controlled arm, they have usually less severe disease and they carry it for a longer time. It was it's not significant, but control arm is younger when compared to the chloroquine. And they started the treatment quite early in the disease, 4 to 5 days, 3 to 4 days. And as you can see, in both the arms, there are asymptomatic patients, those patients with upper respiratory tract, and those patients with lower respiratory. So there was all the spectrum of disease was included, and they were comparable between chloroquine arm and the control arm. And if you look at closely the PCR negativity during the course of study, they just slightly changed the treatment plan. There were 16 patients who were given control, 14 of them were given chloroquine, and 6 of them were given azithromycin along with chloroquine. As you can see here, on day 3 onwards, there is significant decrease in the PCR positivity or significant increase in the PCR negativity. If you can see in day 3, 6.3% the control arm were PCR negative, 35% the chloroquine arm, and 83% the chloroquine and azithromycin arm. And at the end of day 6, if you can see here very clearly, 12.5% here were PCR negative, chloroquine was 57%, and hydroxychloroquine was 100%. Hydroxychloroquine plus azithromycin was 100% effective in making the PCR negative. The data appears to be very impressive once you look at this data alone. This is how this data was published, and people were there was a lot of hype in the media, and President Trump also got carried away. If you look at the supplementary data for control patients, you can see here what happens. As you can see, I remember the inclusion criteria was more than 12 years, but there were 3 patients whose age was less than 12 years. That's a major deviation from the protocol, and we have to take it with a pinch of salt. So French study, is it worth all the hype? The answer is a big no. The first and foremost and the most important reason is excluded patients who became sick in chloroquine. Those patients who were on chloroquine who became sick, they were excluded, and none in the placebo arm became sick. And moreover, as I showed you, control patients do not meet inclusion criteria. That is a very big deviation. We need to, we are not sure why was that done. And there were, and so many cases were in the France, and they could have taken some other controls from some other center too. And there were very small numbers, and they were non-randomized. So these are the basic faults which we need to accept, but that's okay. But this thing, excluding patients who became sick on chloroquine, I think is one of the major factors because of which this study needs a lot of introspection, and we have to take the analysis with a lot of and drawing any conclusion from this study is not possible because of these reasons. There are patients, half of them were given chloroquine control trial, and 30 patients were taken very small numbers, 1:1. To one or half of them, they gave chloroquine 400 milligram per day, much less than the pharmacokinetics study what we suggested for 5 days, and the primary endpoint was negative PCR on day 7. So they also looked at the PCR data at the end of 7th day. What are the results? If you can see the results, and this is 15 patients on chloroquine, these are 15 patients on placebo, PCR negativity is almost similar, 90%. Medium time to negativity was 4 days here and 2 days here. And CT progression, if you can see, there was not much statistical significance, 33% in the chloroquine arm, and placebo arm is 46.7%. So there is no difference. And within the first day of starting either placebo or chloroquine, the patients become febrile. The most important thing is that those patients, most of them had PCR negativity within 2 to 4 days. What does it indicate? Did they have very mild disease? So, and fever also was became normal within 1 day. So most of them had mild disease. I presume they have not mentioned that. And it's a Chinese article, so interpretation of data after translation may be different than the actual data. One patient in hydroxychloroquine became critically ill, and none in the placebo arm became critically. We can't draw any conclusion because 1 out of 15 can be because of just chance. All patients recovered. There was no side effects to any of these patients. So this study has limitations. It is a small study. There is no loading dose because they have just given a 400 milligram, continued for 5 days. What can we conclude? Unlike the French study, we can very clearly say that hydroxychloroquine is not a wonder drug. But definitely because of the mechanical possibility and whatever basic studies have shown us, we need bigger studies with bigger numbers and well-conducted studies with a higher dose. So that is the treatment part. Coming to the prophylaxis part, what is the evidence? If you look at the evidence, why this prophylaxis came is because Indian Council of Medical Research a couple of days earlier recommended hydroxychloroquine at this particular dose, 400 milligram twice a day on day 1, that's 800 milligram on as a loading dose, and then 400 milligram once a week for next 7 weeks to be taken with meals. Whom should be given? They should be given to asymptomatic healthcare workers like doctors or nurses who have been treating these people with COVID, or household high-risk contact of laboratory confirmed cases. They have recommended hydroxychloroquine. Let us look at, and that's why in India I have personally has received more than 100 phone calls from my doctor friends. Can they take it? If you look at the chloroquine, pharmacokinetics, chloroquine and hydroxychloroquine, this is one very, very old study. What they have done is they have given different doses of chloroquine and hydroxychloroquine, starting from 8 tablets to 1.5 tablets. So let us look at the highest dose, 8 tablets of hydroxychloroquine, that is 1500, 1600 milligram. And what is the target we should achieve? As I told you earlier, we should achieve around 0.5 microgram per ml. So it should come somewhere here. And if you give 8 tablets of hydroxychloroquine, it achieves that level within 10 hours of the dose. The level come back to below that. So even if you give very high dose of chloroquine, the drug levels come down drastically within 6 to 8 hours below the level where there is some prophylactic effect. Why does this weekly dose come? ICMR has recommended weekly dose. Weekly dose has been taken from malaria. In a couple of slides, I will tell you why it works in malaria. Weekly dose, this is a study again from very old journal. But what they have done is they have given hydroxychloroquine and chloroquine at 600 milligram as loading dose and 300 milligram as the maintenance dose on every week. As you can see, the required level, I have plotted it in red line, is 0.5 microgram per ml. 0.5 microgram per ml or 500 microgram per liter. So if you have to have here, you can see very clearly here, if you give weekly doses, it does not cross this 0.5. So what does it indicate? Weekly dose of hydroxychloroquine and chloroquine does not achieve the levels to prevent this coronavirus from entering the cell. How does it work? Once a week chloroquine work for malaria prophylaxis. As we know, malaria has two phases, a phase in the liver and there is a phase in the blood. And then it comes out and causes the disease. This is a liver stage and blood stage. And chloroquine acts as the blood stage prophylaxis. And how does it act? Because one of the chloroquine's most dramatic characteristics is that this, even if the concentration in the blood plasma is very less, the parasite has concentrates it to a 1 million times higher, to much higher level than the blood. Parasite vacuoles concentrates this drug, and so the drug can very well act on the Plasmodium vivax or falciparum. The life cycle of corona is not at all similar to malaria. It doesn't have multiple phases and it multiplies very fast. Malaria, as we know, is a slow multiplying thing. So there is no rationality I can see in adopting the same protocol here. How much drug level will be required for prophylaxis? As I told you earlier, there is no real-time data, real data available. But what can be adopted from whatever basic study, which can be grossly wrong, is 0.5 microgram per ml should be okay. And we have very clearly seen from multiple pharmacokinetic studies that once a week dose will not achieve that. And there are two currently undergoing randomized control trials. One is Oxford and another in Minnesota, recruiting thousands of healthcare workers, giving chloroquine to some of them, and some of them being given hydroxychloroquine, and some of them giving placebo. So these are, both of them are Oxford study and Minnesota study. One of them is using hydroxychloroquine, the other one is using chloroquine, and they're placebo controlled trials, and they are using daily doses at much higher doses. So weekly dose does not, they have also not started weekly dose of prophylaxis. So this study, so as I told you earlier, we need a dose of 0.5 microgram per ml for prophylaxis. This is a study which was published in Journal of Rheumatology in those patients who are taking hydroxychloroquine for lupus. And very clearly, you can see that 80% of the patients in the long term achieve this 0.5 microgram per ml if they are given a dose of 300 milligram daily dose. So, so what does it mean? It's very clear. It's a huge study. They have done the blood levels at multiple time points, and they have told the patient to take it properly. And if they do it properly, 80% of them achieve 0.5 microgram per ml, which is what is probably required to required for the prophylaxis. And these levels are achieved with a dose of 6.5 milligram per kilogram per day, not a weekly dose. It has to be taken on a daily basis. So looking at all this data, we can conclude that if you want to have a prophylaxis, you have to take 300 milligram dose on a daily basis so that you get some protection during the time of exposure. And the people are over concerned about whether it can cause toxicity. There was a single patient who had a level of very high levels of 2000 in the setting of renal failure. Others, none of them had toxicity levels during the course of the study. Looking at the toxicity, chloroquine has been used for lots and lots of time, lots and lots of patients with rheumatoid arthritis and lupus. So you can see here clearly the side effects are very low. The most important toxicity was the GI tract, some mild nausea or anorexia. This happens especially when they're giving higher doses. They can cause some patients can come with abdominal cramps. Pruritic rash is one of the major side effects what we have seen in clinical practice. Around 5% of them develop pruritic rash. Long-term toxicity are really not an issue here because we are not going to give it for a long time. And another issue, clinically what we have seen is exacerbation of psoriasis can happen, and cardiac and neurotoxicity is all very, very rare. It can happen 1 in 1,000 or even rarer to treat. So cardiac toxicity, QT prolongation, neurotoxicity are extremely rare. The only thing is when you compare azithromycin and chloroquine, there is a chance of QT prolongation, which has to be kept in mind. So it is safe when compared to antivirals, and even when compared to tocilizumab, which is being tried, other immunomodulators. This drug appears to be much safer, no doubt about it. So what is the role of hydroxychloroquine in COVID? As I told you, it is mechanistically plausible, very appealing. Basic studies and cell culture experiments support the use. It's usually very, very safe in recommended dose. There's no doubt about the safety. Safe, is cheap, is widely available, but the problem is the efficacy. French study, as I showed you, there's a lot of flaws. They have excluded those patients who became sick from the analysis, which is not ideal or not recommended. And Chinese study, there are very low numbers of 30 patients, and they have used the lower dose, so it does not support the use. So what we can conclude is not a magic drug anyway. It doesn't cause what's claimed by the French study, but it can be used at 800 milligram on day 1 and 400 milligram for 5 to 10 days. But how did they arrive at those? Because looking at the pharmacokinetic models. And we have to be very clear that this evidence and this slide may require modification on a day-to-day basis when the new studies arise. Till further evidence emerges, we can use this because it is cheap and is unlikely to cause harm. Having said that, we don't have any evidence at this point to recommend as it as a first-line therapy. And we have to be very clear, using a clinician should be very clear that it may not work in every patient, and we have to look for the more data which has to come up from China and others. The French group may publish their long-term data in coming weeks. So what about prophylaxis? There are no studies yet. There are 2 large randomized controlled studies going on. Once a week is unlikely to work, as I told you, because of the reasoning. Daily dose may work, but personal protection using PPEs and N95 mask is much more important, and social distancing is much more important. By taking hydroxychloroquine may lead to overconfidence that I am protected of because of hydroxychloroquine, and it will lead on to unnecessary exposure, and it may lead on to spread of coronavirus, and people can really harm themselves by taking this drug if they are not clear of the scientific basis and what is the real evidence for prophylaxis. This is my last slide, just showing you when the HIV was discovered in 1980s. Inhibition of HIV, the people have tried on chloroquine. This was one of the studies, and this is another study which was published in 2001. What they have done is they have the control, and they have added different dose of chloroquine, and they could show that chloroquine inhibits the entry of HIV virus into the cell. But because we have more potent antivirals and chloroquine, the clinical efficacy of chloroquine is doubtful, nobody is recommending it, and we don't use it. The point here I want to make is bench and bedside are entirely different ballgames. What does it mean? The in vitro experiments may not translate into clinical results, and this may lead on to unnecessary outcomes if you try to translate the results in the bench directly to the bedside. But yes, as we don't have many drugs for the treatment of COVID, hydroxychloroquine can be used, but in the clinician's mind, it should be very clear that it may not work. And we have to look for more evidence, bigger randomized controlled trials, which will give us more idea whether this drug is really working or not, and in which patient, which subset of patients, and when. Does it work in prophylaxis? Does it work in treatment? In which subsets of patients? Thank you.